Thank you so much for joining me today to talk about transient synovitis of the hip and the role of sonography in the evaluation and diagnosis of transient synovitis. So, what is transient synovitis? Transient synovitis is an inflammation of the synovial lining of the hip. It's self limiting after conservative therapy, which may include anti inflammatory medication like NSAIDs, rest, close observation, and monitoring. It usually lasts for approximately 3 to 10 days with good improvement within 1 to 2 days. Looking at transient synovitis, it's one of the most common causes of hip pain and limping in the pediatric patients, especially between the ages of 3 and 8 years. There is a male predominance. So if you look at the ratio, it tends to be 2 to 1 male to female ratio. It's usually unilateral and mostly occurs on the right side. The question here is always unilateral? No, I said most commonly occurs on the right side, but it can be bilateral, which is seen in 5% of the cases. So what are those causes of transient synovitis? What is the etiology? In many of the cases, really, we do not know. It's idiopathic, it's unknown. However, there are some predisposing factors, or what we call them risk factors, such as trauma, viral, or bacterial infections, such as upper respiratory infections, parvovirus or herpes simplex virus, and of course, some allergic reactions to drugs and vaccines. What are the clinical presentation of transient synovitis? Because whenever you really mention pain, limping, moving hips of a newborn, or refusal to bear weight on a leg, immediately the differential diagnosis includes transient synovitis and septic arthritis. If you look at both those abnormalities, what you find out, there are some similar symptoms between the two. And what we need to do at this point, the early diagnosis and of course the early differentiation and even diagnosis and the accuracy of the diagnosis between these two becomes highly important, because septic arthritis has potential serious complications compared to transient synovitis. Since today I'm not going to be talking about septic arthritis, I will focus on the symptoms of transient synovitis. And if you take both of them, you find out that transient synovitis tends to be the milder of the two. As you look at the list in front of you, you will notice in there some of the symptoms that the patients present with. It's groin or thigh pain, limping, stiffness, difficulty to bear weight on an affected leg, low-grade fever, if present, but usually no fever. And also when you look at the CBC, the ESR, and CRP, they tend to be normal. In some situation, if the CRP is actually present, in other words, slightly elevated in some situation, but usually these values tend to be within normal limits. Here's actually the key. How do we diagnose transient synovitis on ultrasound if we do not know how to perform the examination? What is the technique that is used actually to scan the patient and to provide proper diagnosis? In this situation, we all know that the choice of transducer and the frequency of the transducer is dependent on the patient's body habitus. But in many cases, we use high frequency linear transducer in such situation. We place the patient in a supine position with the hip in a neutral position, which I will show you a diagram. How is that? Usually what we do in there, when you look at the hip, when you look at the hip and what plane you use, very often we place the transducer in a sagittal oblique plane on the anterior hip. Very often, it's always good to use landmarks. And using the femoral head as a landmark, then you can see the synovial recess, you can identify it, and you can go from there, which I'm going to show you actually an image with some labeling of the structures. Sometimes what happens when we do these ultrasound examinations, we tend sometimes not to know the anatomy a little bit. I'm not generalizing, but sometimes can be very difficult if you don't understand the anatomy or the structures that you see on the image. But definitely the landmarks are important, and I will show you an image to actually to go over some of those structures that you will see when you do that. Another thing that's important for you and I to understand, if the actually patient, if the child is, or whoever, the patient is able to actually to tolerate that some of the pain. I said earlier, put the leg in a neutral position, or that's fine, which is the hip in a neutral position. Sometimes when you have a what we call it is some mild degree of external rotation, and here I'm talking maybe of the hip, 10 to 15 degrees, that can be very, very good. I mean, that can give you better understanding and at the same time position to evaluate that hip. In addition to that, what's important for you and I when we perform this examination is to actually compare the abnormal side or the symptomatic side with the normal contralateral side. That gives you an idea on what's going on. Always use this as a general rule. Compare it to the normal side or the other side or the contralateral side. Very often when you look at the hips and being able to identify the joint, usually normal joint capsule tend to be concave, which I'll show you that as well. And the thickness of it is less than 5 millimeters. Usually it ranges between 2 and 5 millimeters. Should not be more than 5 millimeters. And this is highly important. When you look at the capsule, then what you do is you see if there's a fluid, and you and I know that fluid on ultrasound looks anechoic. If there's no debris, there's no blood, there's no pus, there's nothing inside of it, it tends to look anechoic. And that's what we're looking at it. But because if you look at a joint capsule, the joint capsule tends to have what we call it 2 layers to it. The anterior layer and the posterior layer of the capsule, they're there. And that's something that I will also show you as we move on. So let's cut through the chase. Let me show you some ultrasound images to actually make it easier for you to see what I'm talking about. So when we're looking at this down here, you see the placement of the transducer, the way we'll call it, in an oblique fashion on that hip joint, in the anterior hip. This is what I'm talking about here. This is highly important. This is what you're going to look at that in there. And that will be able to give you the anatomy that you're looking at. So if I am putting my transducer here, looking at it in a sagittal oblique way, remember, usually the groove or the bump or the light, whatever that's on the side of the transducer, tend to be moving, it's on this side. So it tends to be more superior towards the patient's head. So it's going to be somewhere here. And that's why it's better. So as a result of that, you see an image like this. The question at this point, okay, what am I looking at? Oh my God. I mean, where are those structures? What are they? As you know, many of us know, and you do know, when you look at it, usually what you see, this is really truly the capsule that you're looking at. This is the joint capsule. If you look at it, this is the joint space. That's where some fluid is, that's the space. And that's what you see, the posterior layer of the joint capsule. This is also the anterior layer of the joint capsule. And here, this is separated by a small amount of fluid in that space. Here, what you're looking at, if I move down to this image, you were looking at the femoral neck, you're looking at the femoral head, you're looking at the epiphysis there, and of course here the cartilage or the articular cartilage that sits in there. And anterior, because you're coming down, you see the iliopsoas muscle, which is striated muscle, you see it in the anterior portion. So that's, again, this is highly important. When you look at this, actually, the capsule is here. So this is where the capsule. In this situation, there's no fluid in the capsule. What you see is what we refer to is here. You see the anterior, we got the anterior layer and the posterior layer. You see this little tiny echogenic line, very echogenic linear structure that sits in there. So the question that we many times we see people referring to it as the stripe sign. I mean, if you do perform gynecological ultrasound, it's almost like the endometrial stripe. So what is that stripe? I mean, what does it represent? And if you look at it, the stripe, what is representing is actually really, this is this space. Remember, I told you there's a space here. In this situation, you do not see this stripe that we're talking about here. You don't see it. Why? Because there's some fluid is distending and separating the anterior and the posterior layers of the capsule. So now when there's no fluid whatsoever, you take the posterior layer and the anterior layer, they get collapsed, and they form that interface between the two. So the really exactly when we talk about the endometrial stripe, that's an interface between the layers of the endometrium. When there's a fluid inside of it, it tends to distend it. And this is actually a general rule. Remember, whenever you have a space, this is exactly the same situation when you talk about the vagina. You see this echogenic central line because it's a hollow space. And then when these layers are collapsing on each other, you form the echogenic line. That's a general rule. So keep that in mind as you do, because whenever you have fluid in this space, now it starts to distend it. And again, effusion starts to form. So that's, again, just some repetition for you. This is, again, I'm going to repeat it. That's where the femoral neck is. Femoral head is there. This is the epiphysis is there. Usually the articular cartilage is there. This is, again, the iliopsoas muscle. So the acetabulum and the labrum are going to be somewhere higher up here, more superior. So that's where you're going to see them more up here. In this picture, you do not see them. So, but again, pay attention to this anatomy, and I think you'll be in great shape as you move forward. So let's take a look. By the way, also was something I mentioned earlier. When you look at the capsule, this is the capsule. When you look at the edge of the capsule and anteriorly you're scanning, you see it looks like almost in a concave way. And now that's how it looks. That we're talking concavity there. So it's concave. When there's a fluid, there's effusion. Think about what's going to happen to the anterior layer. It's going to push it anteriorly. As it pushes anteriorly, it becomes more convex. That's exactly what we have there. It becomes more convex than concave. So that's, again, what we are talking about. We were talking about earlier. So here we go. So what are the sonographic features? So how do you diagnose it on ultrasound? Now you learn the technique. Now, what are the features? And I mentioned a little bit about normal anatomy, what it is. Now, what are the features of transient synovitis? Number one, you look for fluid. Are there any fluid in that space? In this situation, there's a fluid. I see that in there. So if I want to measure the effusion here, I'll go from here all the way to there. That's the effusion. But of course, you have to remember the capsule goes all the way from here all the way to here. So there's a difference here. Dependent on where you are, you have to be able to, if somebody said, how big is the capsule? Now the capsule is going from here all the way down. But there's effusion. So remember that. Usually the thickness of it all the way is more than 5 millimeter. That's what we said earlier. The capsule, especially when you look anteriorly, tends to be more convex than concave. That's the joint. The absence of the stripe sign. I talked a little bit about the stripe sign. It's gone. You don't see this echogenic line anywhere. It's done. Now both the anterior and posterior layers of the joint are gone. I mean, right? Are gone. They are separated. So they're pushed away from each other. So now the stripe sign or the echogenic linear structure is gone in the center of the capsule. Also, now what you do is your mission is to practically look inside, evaluate this effusion. Do we see debris in it? Could be blood, could be pus, could be some other anything, debris, whatever it is. That's what we need to ensure that that's actually been put on the report, because that's highly important. And I'm not saying in this situation septic hips don't always have debris in this effusion. I'm not saying that. It could be this septic arthritis or septic hip without debris in there. So the idea behind it is you have to actually mention what you see in that effusion. So these are some. It shouldn't be that bad. I mean, once you know your normal anatomy, you know the technique, anything outside normal, you'll pick it up. So that's why in there. But in this situation, it is actually, there is a pleural effusion. It is transient synovitis, but there's one thing missing. If I come in there and I want to prove there's something going on. So what do? I told you earlier, you need to compare it to the contralateral side. So now, even if you take a picture like this, it can be convincing. But to be more convincing, what do? Remember that you look at the other side, and this is exactly what we want to do. We want to compare. We want to be more convincing. So that's exactly what we're going to be looking at. So that's what's important. You look at the one side. Of course, you label it right, left, what have you, sagittal right, sagittal left, and then in this situation, you can see there's some fluid there. Surely there's some fluid. The question is that the fluid that we see here, is it abnormal? Is it normal? Remember, if that capsule, the thickness of it is less than 5 millimeter, you're fine. Usually there's a difference between, I mean, the normal, abnormal size. You'll see at least 2 millimeter or higher, the difference between the two. So that could a good actually number to remember. 2 millimeter difference between the two sides. In this situation, even if I want to measure the effusion, definitely the fluid here is much more compared to this. If I look at the size of the capsule, it's definitely smaller here compared to this. So now I can say in a very confident way that the patient has, on whatever side, has actually transient synovitis. That's all what it takes. So that shouldn't be bad, should not be bad. I hope from this today, you will be able to diagnose transient synovitis on ultrasound. Again, I want to thank you so much for your kind attention, for being with me today. And I have all the confidence in you. You will actually do it. Thank you.